It's a privilege and a pleasure to have the opportunity to be able to talk to you once again this year about, specifically we're going to be talking about going beyond the more common elements of care, and we're going to be speaking about cardiac chest pain. Tomorrow we'll be doing sessions with regards to providing details about each of the aspects of care that are going to be age appropriate. So there's going to be 3 sessions tomorrow, one for the younger children, one for the children of intermediate age, and one for the older young men or women with regards to care considerations. But this afternoon we're going to be speaking just about specific issues with regards to care that may be of interest to you. And one of the things that I'd like to talk about is the issue of chest pain, and I'd like to thank PPMD for their support of these efforts. They have sponsored a conference in Columbus, Ohio, where we were able to involve multiple institutions and multiple cardiologists and scientists to discuss some of the issues that I'm going to be speaking with you this afternoon about. So onward, here we go. Whoops, maybe we're here now. Okay, so chest pain and Duchenne muscular dystrophy is very common, and I'm going to tell you that the majority of the time it's going to be musculoskeletal. As you know, there's skeletal muscle weakness, and as a result of that, those muscles fatigue and can become uncomfortable at times. So I think that as we're talking about this and as we discuss this afternoon, I think to maintain some element of calm is important, because I think the majority of times that you or your family members will be experiencing pain, it's going to be musculoskeletal in origin. Another common cause of chest pain in children or young adults would be reflux, and I think that this is going to be particularly common in this patient population, or in all of you, because of the complications of steroid use. Steroid use results in a higher incidence of gastrointestinal reflux, and that can cause pretty significant burning chest pain. So I think the first types of things that you should be thinking about are musculoskeletal pain or reflux if you're experiencing some chest pain. But we are learning more that it may be related to disease progression in the heart. And I'd like to talk to you a little bit more about what that would look like and what we should do about it if it occurs. So, I appreciate that when I start talking about the heart and chest pain and having it be the potentially disease progression, I realize that this is scary. And so when should we worry? So I think that the overarching theme of all of this is to stay calm and try to use common sense as much as possible. If your child or your family member says, I'm just experiencing just a little bit of chest pain, and 10 minutes later they're out playing and laughing, I think that is something that I'm not going to worry about. But if you have somebody who's experiencing some chest pain, it's crushing chest pain, they're crying, they're clearly in distress, this is something that's different for them and unique, that's something that we're going to want to pay a little bit more attention about it. So some questions to ask when it occurs is, how severe is it? What were you doing when it started? Were you just sitting there calmly watching television, or were you in the middle of a transfer, or were you in the middle of a stressful situation? How long has it been there? If it's just a matter of seconds and it's fleeting and it's just a little bit and it just goes away, that's something I'm not too worried about. If it's there for a prolonged period of time, and how long is prolonged, I think you're going to have to use your judgment with regards to that. That's something that I want to think about it a little bit more. And are there any other things going on at the time? Is your child sick, or are you sick? Do you have the flu? Are there fevers? Is there any other issues going on? So I think using your common sense, staying calm and thinking about it in a rational way is the best first place to start. So what should you do? If you have significant concerns, obviously give your care provider a call. If you have a connection with your cardiologist who takes care of you with regards to Duchenne muscular dystrophy, give them a call. I think that's probably the best person to call. I can tell you that almost every children's hospital in this country is open 24 hours a day, 7 days a week, and you just call the operator and ask for the cardiologist on call. You may not get your provider, but you will have access to somebody who can help answer those questions. If not, if you can't get good help in a reasonable period of time, and your child is experiencing, or you're experiencing significant chest pain, then go to an available urgent care or emergency room. Now, this is going to be an important point, and we'll pause here a little bit, in that be aware of where you go determines the type of care that you will get. If you go to an adult emergency room that sees very few pediatric patients with pediatric problems, you are going to be treated with regards to the problem set that these people deal with most frequently. And if you come into an adult emergency room and you're complaining of chest pain, most adult emergency room physicians think heart attack. And so this, I will emphasize over and over again, is not a heart attack. And so you will, I think, get a little better care and a little bit age and disease appropriate care if it's humanly possible for you to get to an emergency where they care for a lot of children, or it's specifically a pediatric emergency room, or it's an emergency room attached to a children's hospital. So, you know, go to where you need to go, get there first, like they say, you know, call 911 and get to the place of, you know, that's most appropriate. But if you can have that time, get to a pediatric facility. So what will they do? They'll do a physical exam. We'd like them to get an electrocardiogram. We'd also ask them to draw blood for tests. And I would specifically ask to have a troponin drawn. And so what is troponin? Troponin is a protein found in the heart cell that is released when there is damage to that heart muscle. And so this is a protein that's specifically drawn in patients who they do think are having a heart attack, or they do think are having some sort of injury to their heart muscle. So I think the things that you'd want are an EKG and a troponin level drawn, and you want to make sure they do a good physical exam. So if the EKG is changed, that's something that I'm going to be worried about. And now this is the key here. Patients with Duchenne muscular dystrophy have abnormal EKGs. And so if you just go into a random emergency room, an adult emergency room, and you get an EKG drawn, it's going to be markedly abnormal, and you're probably going to incite a little bit of excitement amongst the physicians there who are not used to taking care of patients with Duchenne muscular dystrophy. So one of the things that I think is really nice for you guys to have with you is get a folder and put your children and put your children or your own medical records in that folder. Ask your physician for a copy of your EKG, of the EKG, and keep a baseline copy of that EKG in that folder. So when you need to go into the emergency room or you do get ill, you can show the people at that emergency room that this is what you look like at baseline, and this is what you look like now, and is there a difference? And if there is a significant difference, that's something that we want to pay attention to. It's also important to know that troponin levels, as we have found out from a wide variety of clinical trials that have provided this information and other studies, may be just slightly elevated in patients with Duchenne muscular dystrophy, but they will not be markedly elevated. So if your troponin level is is really high, and a physician comes back in the room and says, you know, your troponin level is high, but that's because you have muscular dystrophy, say, no, that is not what it's supposed to be. It may be a little high, but not a lot high. We actually recently put a cohort of patients together with data from our institution and some other institutions, and unfortunately I don't think you can see this EKG, and it's not that important, but here's an EKG of somebody who was having an event like we talked about, severe chest pain, who had marked troponin elevation and EKG changes, and the top EKG at A is their baseline EKG. The EKG markedly changed, and it's not important for you to know in what way, but then after this episode resolved, the EKG returned back to normal. But the reason why I show that is the EKG during these episodes of severe chest pain will change. And so I think knowing what the baseline is, or knowing where we start, is important. So what's next? So if for example, you go in to be evaluated and they say, you know, the troponin is okay, your EKG looks exactly like it used to, your baseline EKG, and they say, you know, we talked to your physician and they're not that worried about it, and you get to go home, fabulous. Maybe they gave you some antacids, maybe they think it's a little bit of what we talked about, gastroesophageal reflux, maybe they gave you some anti-inflammatories because they think it's musculoskeletal. Onward with your daily activities. However, if they find markedly abnormal troponins and a markedly abnormal EKG, then admission to a hospital may be indicated. And if that happens, you'll be admitted to the hospital because we'll be watching what's happening with your heart muscle. And these graphs here, actually it's a little dirty, but these are the 9 or so patients that we actually tracked with regards to their elevated troponins who came in and were admitted to our institution. And you can see there's actually a rapid spike up, and then over the next several days, these troponin levels return to baseline. So there is an episode of myocardial injury that's occurring, but yet the levels return back to baseline. So once you get admitted to the hospital, we'll need to check serial troponin levels, we'll need to check serial EKGs. We'll also like to obtain a cardiac MRI and obtain some viral titers. I think it's important to note that a cardiac catheterization is not needed. Do not let the cardiologist do a cardiac catheterization because this is not coronary artery disease. However, I will say that with the caveat is I hate to say anything in medicine is 100% of the time. So, you know, there may be some circumstances that they are concerned that there's a coronary abnormality. And in one patient, about 10 years ago, we did see a Duchenne patient who had a coronary abnormality. So never say never, but I'd say the majority of the time a catheterization is not needed. And the cardiac MRI will show an injury pattern. And the pattern is often, unfortunately, interpreted as myocarditis or inflammation of the heart muscle. However, we know that it's probably not viral myocarditis or a viral insult because the viral studies that have been checked are normal. And unfortunately, this injury that occurs with these troponin spikes and these episodes of chest pain may or may not improve with time. So long term, what does this mean? It means that we're going to need to monitor your heart more closely. You may, unfortunately, not recover the cardiac function lost during this event. And we know that I think people, we always say that the heart is a muscle too, and so in the same way that the skeletal muscle is losing function over time, we unfortunately know that the cardiac muscle is losing function over time. So what do we know? Unfortunately, at this point in time, we don't understand what this process is as well as we would like to, and that it may represent sort of episodic microvascular ischemic events related to disease progression. Definitely more research is needed. Therapies will be needed to be developed, obviously, which will target the heart. And inclusion, and we need, which is why we need to include cardiac endpoints in clinical trials. So as you're talking to pharmaceutical companies during this meeting, just remind them to make sure that they include cardiac endpoints in their clinical trials. And I think that they're doing an outstanding job at this moment in time, so I'm very proud of 99% of the companies who are in this field. Awareness is important, so know your child and know yourself, and it's likely that you're going to need to educate your providers about this. Very little information is currently in the literature about this, and this is really something that we've just started to uncover. As we've said, you know, our institution saw one of those young men. Our institution saw one of those young men. You know, the more we look for it, we're finding it. So, you know, if you draw troponins every single day on your child, you're probably not going to pick it up. But it will spike at some point in time. So that's, you know, unfortunately all I have to say at this point in time, and I wish I could tell you what was causing it and what to do about it and how to treat it, but we're not at that point yet. But I do think awareness is the first place to start. And so I'd like to thank you for your time, and I'm more than happy to answer any questions.